Welcome to Between Two Ovaries, your go-to for all things women's health.
A lot of people just say like, oh, my vagina.
Yeah.
And
Yes.
that's
all
not
of the above.
That's not your vagina.
No.
Well, it is.
We're here to cut through the confusion, bust some myths, and give you the facts straight from the experts.
You cannot still believe the amount of people that come to a gynecology clinic saying that they don't look right down there and they need something doing about it.
We're keeping it real, bringing you honest conversations about topics that matter to you.
Everything goes back to the menstrual cycle. Yes, it's a low-risk procedure, but it's not a no-risk procedure.
From periods to menopause and everything in between, we've got you covered.
So whether you're here to learn, laugh, or just listen, you are in the right place.
As soon as I said it,
Hi guys, welcome back to today's episode on Back to Basics inside the female reproductive system.
So,
Yes.
what we're going to do is, the basic plan for this episode is that we wanted to really go back to basics. We've had loads of people that have kind of said, it's fair enough that you're talking about all these things, but we kind of don't understand like the actual anatomy, how everything happens with regards to hormones and hormonal control, and why do we have periods, like what happens with the hormones with regards to the periods. So we're really going to try and describe all these things to you as best we can. So we thought we'd start with the anatomy first.
Yeah.
So outside to inside is
Yeah.
how we're going to play it.
We thought, imagine that you are a little tiny person and you're sat on the outside of someone's vulva, and we're gonna describe what the vulva is, how it looks from the outside, and then we're gonna walk all the way in, all the way through, and we're gonna finish at the ovaries.
Yeah.
So we're gonna describe like what you would see, what exists there, and little bits of relevant information about each area. So hopefully that'll kind of explain in kind of understandable way what the female anatomy is.
Yeah.
Then we'll also talk a bit more about the menstrual cycle and
Our
hormones
favourite
and health.
topic. Okay, you start then.
yeah,
From the
okay.
outside.
So we've got, if we are stood outside, we've got the external genitalia first. So we've talked about this a little bit before, but looking from the bottom up, we've got the vulva. So the vulva is a general term that describes like all of the outside.
Yeah.
And we've talked before about how the vagina's on the inside and the vulva's on the outside. Yeah. But the vulva isn't just one thing. There's lots of different parts to it. So we've got the labia majora, or the outer lips. We've got the mons pubis, which is basically the pubic hair on the top. And then you've also got the labia minora, which is the inner lips.
Yeah.
Then next to that, you've got sort of at the top of the labia minora is the clitoris and the clitoral hood. Very important. We all want to know where that is.
Yeah.
And then just below the clitoris, there's the urethra, which is just a fancy name for the tube that connects the bladder to the outside. So when you go for a wee comes out of the bladder through the urethra into the toilet, hopefully.
I think just
if you're on the toilet.
just a very quick, as an aside, we have covered this before in one of our other episodes, saying that everybody's vulva is different.
Yes.
Please don't compare your vulva against especially porn that you might see, because it's genuinely not normal. Everybody's vulva is very different. To have symmetrical labia is not a thing. To have small, tight, neat labia on the whole, not a thing, and doesn't matter. They're there to do a job. So really have a look at we were discussing about the labia library before, how
Google
important
labia
it is
library.
for people to kind of have a look and understand why we have these. And with regards to like the clitoris, when people are saying they don't like that because it's unsightly, it's got like all of your nerve endings, like all of your nerve endings, more nerve endings than the head of the penis. So like
It's actually really more important than a penis.
yeah.
Let's just throw that out there.
So it's really important that people understand that there is no like one size fits all, that everybody looks the same and anybody looks different or abnormal. Everything is pretty much normal with regards to your vulva.
Yeah. And it probably also is useful to say, like, if you think about the face of a clock, we can put like the clitoris at sort of 12 o'clock.
Yeah.
The vagina's then at like 6 o'clock.
Yeah.
Labia minora, the smaller lips are around the outside, sort of between, around there and around there.
Yeah.
They're kind of the main outside bits that you've probably heard of or seen and know what they are, if you've got your own names for them or you know the actual like anatomical terms. Obviously the vagina, which is like the vagina is the muscular tube from the outside, so from the vulva, up to the neck of the womb, the cervix. But there's sort of like outside of the vagina, there's a few interesting bits of anatomy that you may or may not have heard of. So there's the Bartholin's glands. Do you want to?
Yeah, so the Bartholin's glands, so if your vagina is, as you said, kind of the hole, if you were looking at the whole of the vagina, if you say at kind of 5 and 7 o'clock, just inside the vagina would be where your Bartholin's glands are. Now, these are glands that in normal everyday life you would have nothing to think about them because they produce the secretions like lubrications if you're having intercourse, but they can get blocked. So we do see quite a lot of people that will have something called a Bartholin's abscess, a Bartholin's cyst. So they will come to hospital really uncomfortable in the vulval area. You'll have a look, and when you examine them, if you put a finger into the vagina, you can feel that there's a cyst just inside the vagina.
Really
it can
painful.
be so painful.
Does not sound good.
No, it really can be mega painful for people. And it's that kind of thing where if you've got something that's uncomfortable, get someone to look at it.
Yeah.
Like, don't sit at home with something like this, because a lot of times if you sit on them, well, you can't sit on them because it's so uncomfortable.
Yeah, you mostly will be pacing up and down.
Yeah, you know when someone's got a bad Bartholin's because they won't be sitting.
Yeah.
So is that something you can like avoid? Is that like personal hygiene,
good
or is it just
question.
naturally occurring? Some people get, some people don't.
Totally great question, and I think it's just some people are more prone to
to it,
them,
yeah.
and when you've had one, you're more prone to having them again, which is really
That is
really
unfortunate.
annoying.
Yeah.
I think it's like one of those things where the anatomy isn't perfect. So like the tube or the duct it can be quite
Becomes
narrow,
blocked.
Oh yeah.
and it can become blocked quite easily. It doesn't mean you've done anything to cause it. It can just happen.
Yeah.
But then if you have any inflammation, that might make you a bit more likely to get it.
Yeah.
If you have one, then we tend to advise avoid shaving. And they can sometimes be associated with STIs, but not always at all.
Okay,
like
there's
mostly
no,
not at all.
yeah.
But there's a few things that might make you a bit more likely to get one.
And what would you do if someone came to the hospital with one?
So in the first instance, it depends like how uncomfortable it is, how big it is, and whether they've tried antibiotics. Some of these can be kind of nipped in the bud. You can have antibiotics and they will settle. They might come back again, but they might settle. Some of them start draining themselves. So if they've come and they're like, oh, I've started kind of having this pus that's coming out, that's kind of well, it's gross, but also like a good thing because your body's kind of done its job and it's getting rid of the abscess that's there. But
And
you
there's a
would
bit
give
of, like,
antibiotics for that.
General advice as well with, if it's infected, then you would need antibiotics.
Yeah.
But if it's sort of like, if you can feel there's a little lump there, it's a little bit painful, it doesn't seem like it's infected, you can try things at home like having a hot bath, trying to encourage
sort
it
of soaking it like another abscess.
Yeah.
Well, it's like a big spot, like
Yeah.
you would have anywhere else, but it just happens to be in the inside.
Yeah,
of the
so you can try and encourage it to drain. People recommend sits baths, which is like a salty water bath.
Oh, yeah.
To try and, I don't think it's nice. I think it's probably quite painful. But you can try that as well as if you need them antibiotics.
Yeah. The other thing that we sometimes have to do is open them up. So we do something called marsupialization, which means we open the cyst but we leave it open.
Okay, and
because you want to leave it open because it's kind of a drainage system and you want to leave it to kind of drain. You don't want to be closing that back up because it will just reform again. So we often will take people to theatre for that.
But you can do it under local anaesthetic as well.
Yeah.
Different places do different things.
do different things.
But it's also dependent on you, the size of the cyst or abscess, how painful it is and what's available. Like, but you can treat them. The main thing, it can go away.
The thing with all of, and that's potentially why we've just highlighted about a Bartholin's abscess, because everything we'll have seen it before. Like, genuinely, it's really uncommon for someone to come to hospital and you're like, God, I've not seen that before. And if I've not seen it before, somebody else will have seen it before. So come, get checked out, make sure that what you've got is something that needs treatment, doesn't need treatment, and isn't going to progress to something that we are worried about. So highlighting that is something that is really quite common. We see it all the time. Nothing to be embarrassed about. Come and have it sorted.
On the topic of glands, there's some other glands that are also, I would say, less well known than the Bartholin's glands. So had you heard of Bartholin's glands?
No. I'd never heard of an abscess there either.
Okay.
We see lots, and not even just Bartholin's.
Yeah.
We see vulval abscesses, and those can be by shaving. So if people
From,
are
like,
shaving ingrown
hairs.
hair and don't get anything seen to because they're like, oh, I don't want anybody to see down
Yeah.
there, get bigger and bigger, and they will end up with just really
get quite
uncomfortable.
Yeah. Do
really
you think we should
painful
describe what
episodes.
a cyst or an abscess is?
Yeah, good.
Yeah,
We should.
so like a swelling under the skin. So it would feel not like a hard lump, it would feel like, I was going to say a fluctuant lump, which I'm not entirely sure.
Still don't know that word.
Yeah.
Like
If
a
someone-
soft bouncy thing.
Yeah.
So if this, a cyst is
Like a
usually...
balloon. So
Yeah,
if
like
you felt a
There we
balloon,
go.
it's like, I was trying to think of something very quickly then.
Think of a water balloon.
Yeah,
those little
yeah.
balloons.
Yeah.
So a cyst is usually sort of a fluid filled.
Yeah.
Not always fluid filled, but usually fluid filled.
Yeah.
I'd say. And yeah, if you imagine like a water balloon under the skin and you press it,
That's what
that
it
kind
feels
of
like.
bounciness.
Yeah, okay.
Yeah, that tells
Because
you
I
it's
feel
full of fluid
lumps
or
and
pus.
bumps can be quite concerning
Yeah.
sometimes.
Yeah.
People can worry.
And an abscess in relation to a cyst is an infected cyst, so it's
Okay.
full of pus usually.
Mm-hmm.
And a lot of the time, abscesses, they don't always need surgical treatment.
No.
They can go away with antibiotics, but if the antibiotics haven't worked, they might need draining just to help the
That's your
body
next
get rid
step,
of
yeah.
the pus. Yeah.
So what we're doing is when we're draining them is, you know, when people are finding that point with a spot that they're about to, like, we're finding that but with a scalpel.
Valid.
It's very satisfying.
Yeah.
I think I'd like that.
Like
Not to have it
people-
done. I'd quite like to do it.
People pop it.
Yeah.
So there's other glands.
Other glands. So there are two little glands called Skene's glands. So these are, so I described the urethra, the tube between the bladder and the outside. So just next to either side of the urethra are these little Skene's glands.
Yeah.
So again, they're smaller than the Bartholins, and what they do is they secrete lubrication. So during arousal, it's also supposed to have potentially some sort of like antibacterial properties, the lubrication from both glands. So it has a function. And yes, these are smaller. They tend to cause less problems than Bartholins. We
Yeah,
don't see them
we
getting
don't
blocked and
really see
infected
them,
as much,
no.
but they are there.
Yeah. With regards to urethra, just a really quick aside. So this is the tube that takes your urine, so your wee, from your bladder, so where we store our urine, to the outside world. And in a woman, the urethra is really quite short, so about 4 centimetres. So when people kind of think, oh, we get urine infections all the time as women, and men don't seem to get them. If you think how long the urethra, how long that tube is in a man compared to how long the
varies in
tube is.
length, doesn't
Well,
it?
it will vary.
Depending on
Generally longer
help
generally longer than in a woman. That's why women are way more prone to
The
urine
infection
infections.
Oh,
can
okay,
get
because it's so much
quicker.
closer.
yeah, much more common, much less common for men to get urine
Yeah,
infections.
really
actually.
uncommon for men
Yeah.
to get urine infections.
Whereas like UTIs are sort of like a buzz thing for women, aren't they?
Yeah. And there's also like UTI, so urinary tract infections, but you can also just get cystitis.
Yeah.
So the difference being cystitis is inflammation of that tube. It doesn't always mean, well, it can be inflammation of the bladder. It doesn't always mean infection.
Yeah.
But a UTI usually means infection.
Yeah.
with
And
antibiotics.
what usually causes a UTI? Because I've heard someone say before that a UTI is an STI, which is
No.
it's not.
No. So it's usually, most common culprit is E. coli. The reason being that E. coli comes from the bowel, and obviously the urethra and the bowel are fairly close
White
together.
front to back.
Always wipe front to back. But even if you do wipe front to back, you can get UTIs. But most common culprit is E. coli. It can be other things.
Yeah, there's lots of different things that can cause urine infections, and some people seem a lot more prone to it than others.
Yeah.
When you're postmenopausal, you're a lot more prone because you've got that, as we were talking in our HRT episode about the atrophy, so your tissues aren't as good because you've not got all that estrogen there. So there's loads of things that are related to urine infections.
And it's usually treated with antibiotics.
Yeah.
If it's a bacterial urine infection,
I love how you say
Yes.
trat. I just love that. It's like a proper little Yorkshire thing, isn't it? Trat. I love it. You said it in another one, and I was like,
I was just
love
like,
it.
I've never heard it.
I get told that that's not a word.
It's not a word.
Yeah.
No,
Is it not?
sorry to break
Yeah,
it to you, but I love
I
it.
use it.
Yeah.
I think it's
I'm
lovely.
going to stick with it.
Yeah, no,
So yeah, we also wanted to mention the hymen,
Yes.
because another piece of anatomy. So we've gone, we've done the outside. We're sort of stood on the entrance to the vagina.
Yes.
We've looked at the Bartholin's glands.
Look, it's got that.
We're looking in the vagina, and sort of just at the entrance is the hymen. So The hymen is it gets a lot of like a bad or a bit of a
It's got a reputation.
understood reputation.
Yeah.
I think.
I think
just
it's got
to-
involvement in different cultures as well.
It does,
Yeah,
and we
definitely.
I like the hymen. I think it's interesting. It's got zero function, but as an anatomical area, I think it's quite interesting. So all females have one. You're born with it. So when you're in the uterus, when you're growing, it covers the entrance to the vagina completely. So it's like a sheet.
Oh, it
And
closes.
then
It's like the door.
It's closed when it forms, but before you're born, it actually opens.
So before you're born.
Before you're
Not
born.
when you have sex. Before
So
you're born.
everyone, if it's normal, everyone will have an opening in the hymen when you're a baby. There's a really small number of people that have something called an imperforate hymen, which is when it doesn't open, so it's just closed. And that can cause problems. But for normal anatomy, it should be a little bit open. And then when you're a baby, up to puberty, it sort of just sits there as like a little, it's kind of like a polo shape, very thin, not very elasticy, just like a little polo-shaped bit of tissue at the entrance to the vagina. And then when your body's flooded with estrogen, it starts to change in size and shape. So then it becomes, in most people, like a scrunchie. So it's like fimbriated, we call it. So I guess it's like...
Got like little fingers.
like a scrunchie.
Okay.
But in some people, it can be different sizes and shapes. It can be like a moon shape, or it can be a scrunchie. It does differ in different people, but the most common is a scrunchie type. And then it can be damaged. So when you exercise, use tampons, or have sex, then you can get small kind of like tears or damaged areas in the hymen. But this is the biggest myth, that if you have a hymen that doesn't have any tears in, that does not mean that you've never had sex.
Yeah.
If you have a hymen with tears in, it doesn't mean that you've had sex.
Yeah.
So it cannot be used to judge whether or not someone has had sex. And in some cultures it is, and it's completely wrong. Like you can't rely on it. It's not it's not a very reliable piece
not
of
a medical test.
anatomy. No.
Imagine.
So it's there, we see it, but it doesn't really have a known function.
Yeah.
And whereabouts in the vagina is it placed?
Just at the entrance, so it varies slightly with different people, but if you've just stepped into the vagina, it's all around.
Okay.
And then actually once people have got a bit older, maybe had children, then there might not be as much of it visible because it's been stretched so much in childbirth.
Yeah, so you can usually see like a hymen remnant. So like the
Okay.
remainders of the hymen.
Yeah.
So when someone's had a baby, when you look in the vagina later on, you can usually just see like a little bit of where it's
was.
been,
Yeah.
basically.
And then that's something that sometimes people will see, not know what it is, and worry it's something abnormal.
Yeah. Because it will change after you've had a baby, because
Yeah.
So then you see
Yeah.
something different, you worry.
Yeah.
Yeah.
Okay.
But yeah.
So you know how we've said it tears? Sorry.
Hmm.
One of the things that I think a lot of people get told is like the first time you have sex, you'll bleed. Is that if the hymen tears, you bleed?
Yeah. Yeah, so when it tears, it can bleed. It doesn't always bleed.
Okay.
So if you have sex for the first time, you may or may not bleed. You may or may not have already torn your hymen doing something other
Very
activity.
Totally different, yeah.
It may or may not tear.
Yeah. Okay. I just feel like that's one that
can't
people
be
say a
relied
lot.
on.
Yeah.
Oh my gosh, yeah. And I think it's like kind of a film movie type
Yeah.
situation.
Oh,
like-
definitely.
I've seen a lot of films where it describes that.
Incorrect.
Alison, incorrect.
Wrong.
But yeah.
Okay,
Do you wanna walk
so we have moved on and we are now in the vagina. So the vagina is a muscular tube. It's a blind ending tube, which means it goes nowhere. So there is a cervix at the top of this. So your cervix looks a bit like if you made a fist and looked at it like at the end of your fist. Yeah.
Okay.
So if you made a fist and looked with your thumb finger like that, that's kind of what your cervix is like. It's like a little circle. It'll look very different on all people. Depends if you've had children or not. When you've not had children, the cervix can be really quite hard and have like a pinpoint for an opening.
Okay.
And also when people have had kind of, if you've had treatment because you've had a cervical cancer or cervical pre-cancerous cells, we do lots of treatments to the cervix, which can actually mean that you end up with a deficient cervix, or a cervix that's shortened, or a cervix that's really very closed and doesn't really have that opening.
Okay.
So cervixes can look very different. So the vagina changes at different times, but it is kind of this stretchy muscular tube, basically, that with the cervix at the top, nothing can go anywhere, because people kind of worry about like a tampon or losing something, and it's not the same. So if you pop something into your bottom, then you potentially can totally lose it if it's not got something on the end of it, because your bowel is a tube that goes from your mouth to your bottom.
Yeah.
Your vagina is not that at all. It's really very different. It's just this tube that doesn't go anywhere. And then you have the cervix at the top. The cervix is what you take the smear from. So people, I think they've had smears when they've had vaginal swabs or vice versa, or think we've been into the womb to do a smear. That's not the case. So the cervix, this end that we've just been talking about, is where you take the smear from when you get called for screening for looking for HPV and cervical changes that potentially could
lead to
relate
cancer.
I felt like that was coming there.
Yeah. So that's, I suppose, anything else interesting? I mean, there's lots of interesting things about the cervix, but
dilates when you're having a baby.
Yes.
She somehow goes from pinpoint to 10 in theory.
So also, because you've nicely described what it looks like when you're looking at it if we're inside the vagina, but it's long. So it's a tube still, but it's quite fibrous, which means it's quite tough tissue when you compare to like the vagina or the vulva, which is generally a bit softer. It's really hard.
I don't know if people can see, but the tube, like we're saying, like your fist is this like maybe 4 or 5 centimeters long. The cervix is the same in that sense. It is quite a long structure.
So that means in labour, so the first part of labour is actually getting the cervix from the like 4 or 5 centimeters that it is down to completely, it's called a faced, which is when it's sort of like thin. So it has to become
so she
short,
shrinks first.
Okay.
But it's not shrinking,
no, but
it's going like back and into.
Flattening, widening a bit.
So it's not kind of disappearing.
Yeah.
It's going into what was there. Does that make sense?
So if she stood up, the bottom goes up.
Yes.
Okay. Because I'm thinking the top
So
comes
the bottom goes into the sides.
Okay.
Yeah.
And then once that has mostly, become flatter, then it will start to dilate. Sometimes it dilates a bit before it completely shortens, but typically
that time that it
first and
takes
then
for your
dilating.
cervix to kind of really shorten out is the really long time that people are like, but I've been in labour for 500 days. And you're like, well, it's changing. Your cervix is changing.
And I think that can be a really really frustrating time when you've been contracting. You might be in the latent phase of labour, so you're in pain, you're contracted, you can't sleep, and then you come in maybe a few times in, I'm 1 centimetre, you're still 1 centimetre. That's dilation, but you might have gone from 4 down to 1 in terms of length. So it's that first and then you'll dilate, but I think that can be really
something is
frustrating.
Still happening. You're just not ready to get the baby out yet.
But it is amazing, isn't it?
Yeah, it's crazy.
Shorten like that.
Yeah. When you go for a smear, what is the process?
Okay, so we'll talk about this fully in one of the other episodes, but realistically, when you go for a smear, it's really straightforward. People that do smears all day, every day, and it is not a thing for them to be doing the smear. I know it's a big deal for you to be having the smear, but definitely not for the people who are taking it. You will have a speculum inserted. A speculum is a device that means that we open your vagina so that we can see your cervix. If not, we wouldn't be able to see your cervix. When the speculum is in the right place and we can see your cervix, you use kind of a brush that just takes some cells from the end of your cervix, and then we pop that in a little pot and send it away, and that is it. Really doesn't take a long time. It's not excruciatingly painful. It's just, I feel like it's just
of an annoyance
to
have to do it.
Yeah, it's an annoyance, and it's really difficult because it's that thing that if you are like, I'm really anxious about it, and your bum's really tight
Tense,
and everything's really tight, then it does make it more uncomfortable. But it's easy for the person taking it to be like,
relax, you'll be fine.
I know.
Because
I think a lot of the time when it's someone's first time ever having a speculum as well.
Yeah, and I think as annoying as it is, you don't have to go very often. It's every 3 years until a certain age, then it's every 5 years. But if you go every 3 years and you have a smear and it's normal, great, reassurance. Yeah. But if there's anything abnormal in there, you want that to be treated early.
Yeah.
Because the whole point of this is, it's not just, just doing it for fun. It's to prevent cervical cancer. Mm-hmm. And you don't want cervical cancer if you can avoid it. So having cervical screening, and we will talk a bit about screening in a different episode about ovarian cancer, but this is one screening method that works really well. So make the most of it.
Definitely have. If you're called for a smear, you should have a smear.
Definitely, yeah.
Okay, so that's the cervix.
Yes. So we're going beyond. So it would be really hard to walk through the cervix, but let's just say that we've managed to do that and we're in. we're in the uterus. So inside the uterus, we've got different layers. Again, it might be useful to use this little...
So we're now inside the womb. So this is where a baby would grow. This is where your endometrium grows every month and is shed from.
And what's the endometrium?
So the endometrium is the lining of the womb.
It's like the inner cavity.
Yeah.
Which is often, if you imagine it in 3D, but in 2D you often draw it as a bit of a sort of T-shaped triangle. But in 3D it's different to that. I guess it's kind of like a mushroom.
Yeah.
If you've got the stalk and then
it's difficult because I think people don't actually realise that you can't see into the lining of the womb like all the models and stuff because it's flat. So the edges are opposed, so the edges are against each other. The only way that you can see inside the lining of the womb and have a look round and see if there's anything wrong in there is to put water or another substance inside so that it actually makes the womb bigger, opens it up so that you've got a view to see inside.
Yeah. So it's like it can be hollow, but it's sat so close together that it's not.
Yeah.
Because like on that model, we've got all this open space, and that's not how it is inside.
Ultrasound is quite a nice kind of comparison there. So like when you go for a vaginal ultrasound scan or even an abdominal ultrasound scan, you're looking at your womb, and inside your womb you'll see the endometrium because it looks a bit different on the scan.
Yep.
And the sides are sort of opposed, so they're touching because you know there might be a tiny bit of fluid in the cavity, but they're sort of next to each other. Yeah. So on the ultrasound you'll see just like a thin stripe, and then you can measure the endometrium. Whereas with something like a hysteroscopy, which is the camera that goes inside the womb, when you fill the cavity with water, the edges are no longer touching, they're sort of further away.
So you can see them distinctly.
So then you can see them more distinctly.
You can have a look and check everything out. And when you're doing that, so when you're having a look inside the womb and you're looking to see if there's anything there like a polyp or a fibroid or anything like that growing, and we will discuss about these different conditions later, you can see also where your fallopian tubes come in. So you can't see into the fallopian tubes because you have a lot of people that are like, do my fallopian tubes look okay? Do my ovaries look okay?
Like
you can't see any of that.
Yeah.
But you can see the kind of the little holes that are coming in to the womb. So you can see that they have two and that they're in kind of the place that you thought that they would be.
So to be able to see the ovaries and the fallopian tubes, would you need to have an ultrasound scan?
An ultrasound scan, well, fallopian tubes you only see on an ultrasound scan if there is something wrong with them.
Okay.
Because the fallopian tubes, again, are structures that are flat. So unless there's something like fluid in them, which we don't want there to be fluid in them, but unless there is something like fluid in them, on an ultrasound scan, it's not good to pick up, but you can't pick up fallopian tubes very well. So fallopian tubes are the tubes that connect the corners of your womb out and to the edges, and then that's kind of your it's the connection to the ovary, but it's not an actual Velcro connection. So they're the ends of the fallopian tubes are close to the ovaries, but to see the fallopian tubes and the ovaries you would need a kind of a diagnostic procedure like a laparoscopy. So we put a camera inside your tummy button, have a look round, and we would be able to see the fallopian tubes, the tubes, and the ovaries in that way, rather than on an ultrasound. Well, you will be able to see ovaries on an ultrasound, but rather than on an ultrasound, rather than with that camera from down below, to be able to actually visually see them, would be a camera inside your tummy button.
Yeah.
Okay.
The other thing with the womb or the uterus, so we talked about the inner lining, the endometrium.
Yep.
We'll go a bit more into detail about that when we talk about menstrual cycle, because more relevant there. But that's the inner lining, and then you've got the muscle layer which surrounds the endometrium, so that's the myometrium muscle layer, and it's quite a thick muscular layer that helps with contractions in labour. Also when you're sort of having your period, your uterus will contract still, so you can get period pain from that contraction, trying to stop the bleeding. And then just on the outside is a layer called the serosa, which is just a term for like outer layer of an organ. So there's three sort of layers to the uterus.
So that's what the womb looks like, and it's really quite small if you're not pregnant.
Yeah,
so,
it's often pear-shaped,
I don't think people realise how small it is. When you're not pregnant, it really like the size of your fist will be the size of your womb, basically.
And also it's so the way it sits on your other organs in your pelvis. So you've got, if you imagine someone front to back, you've got the bladders at the front. So the bladder's sort of near the front of your abdomen, the tummy, near the bony bit at the front of your pelvis. You know, if you press down, you can feel that bony bit there. The bladder's sort of just behind there. And then behind the bladder is the womb or the uterus. And it points in different directions, and that's normal.
Yeah. Doesn't matter which way it points.
Most people have what's called an anteverted uterus, which basically means it sort of sits facing forwards on top of the bladder. But some people have a retroverted uterus, which means it faces backwards. I always say it's just like being right and left-handed. It doesn't really...
it genuinely doesn't
But it also
matter.
changes in the same woman, different times of the cycle.
When you're,
It can change
when you're
size and
scanning
shape.
somebody, you can start scanning and you're like, oh, the womb's been in a really annoying position and you can't see. So you'll go and do the ovaries and then come back and be like, oh,
It's moving.
in a much
She's
better
there.
position now.
Yeah.
So it's not like it's not a static structure. It's not.
Okay.
But
The
then if
top
it-
of the womb is not stuck to anything.
But it's not floating round.
It's not
No.
floating down. Not
She's
like,
not
you know,
coming
back
off
in
and-
the day when they used to say that everything was caused by a wandering womb, you know, like in old ancient medical, like Greek. If a woman was like having a heart attack, they'd be like, the womb has wandered. It's moved up and it's causing her to die. You need to give her some
rid of it.
sex. Like, that'll make it better. But yeah, so the other thing about when it points forwards or backwards is that actually it can make it a little bit harder to see your cervix if it's pointing backwards, because obviously your cervix is connected to the womb. So if you go for a cervical screening smear and your womb is pointing backwards, it might just be a little bit harder to find your cervix. And one little trick for that is they might ask you to put your hands underneath your back.
So like
and
arch your
tilt
pelvis.
your pelvis
Okay.
forward.
Interesting.
And you can use like wedges to sit on to make it easier. But yeah,
So that is
womb tubes.
Womb tubes attached.
The fimbrial ends are interesting, I think,
Yeah.
of the
Are
tube.
they the wafters?
They're the wafters.
I had to get the word in.
The wafters, like spirit fingers.
Yeah.
Bring it on. So yeah, do you want...
So basically, the fallopian tubes are not attached, glued, velcroed, etc. to the ovaries, contrary to what I think most people
Well,
understand.
a lot of the diagrams make it look as if the ovaries are held by the fallopian tubes.
So they're kind of all three structures. They're all in place loosely with different kind of ligaments, and they all obviously have blood supplies, but they aren't stuck, basically.
Yeah.
So when an ovary releases an egg, it is wafted into the, or wafted / kind of welcomed into the fallopian tube with these kind of welcoming fimbrial fingers. Then it would, the egg would then travel up and through the fallopian tube.
Yeah, and also interestingly, if you are trying to get pregnant, or, you know, if you've had unprotected sex, around the time of ovulation, the sperm will actually travel to the tube. So it goes all the way through the womb into the tube, and often will meet the egg in the tube and fertilise there. And then the fertilised egg will travel down into the endometrium and implant.
Does the fertilised egg ever get stuck in the tube?
Yes. So you can
Ectopic
get
pregnancy.
ectopic pregnancy, yes.
So pregnancy in the wrong place.
Yeah, which I guess we'll maybe cover on a different episode
actually,
rather than
I think
going
we
into
should
too
do
much
one on
detail. But ectopic pregnancy in the wrong place, most commonly in the tube, will never become a normal, healthy baby.
Cannot be
Needs
moved
treatment
to
or
a different
monitoring.
place, cannot grow there and become a normal, healthy pregnancy.
There have been studies that have like implanted ectopic pregnancy in the uterus. They do not grow. Like there is no way that potential baby could be saved, and it will not grow into a normal pregnancy.
And that's dangerous for the mother.
Dangerous. It
Very
can
dangerous.
be life-threatening. Yeah, not always, but can be.
Yeah.
I forgot to mention when I was going from front to back that at the back of the uterus is
Bowel.
the bowel, the rectum. Really important. All our colorectal friends will be like, God, they don't care about the bowel. But yeah, so bladder, uterus, and then rectum, bowel.
Yeah.
They're all very close together, and I think this probably come on to this now. Actually, it's quite relevant for when you have pain in your pelvis. It's hard to know exactly what is the cause of the pain from where you feel it.
Yeah. So the pelvis, we would say anything in like the lower tummy. So anything kind of below your tummy button.
Like where the bony bits of your hips are.
Yeah.
Sort of there down.
In that kind of like V shape.
is your pelvis.
And people will say that they've got pain at various different times. And if you think everything is so close to each other, so you've got your bladder at the front, then you've got your womb, then you've got your bowel. Like they're all there. So when we're like, oh, we're not really sure what's causing the pain and we're trying to get to the bottom of things, you can understand why that would be an issue, because like they're all in the same place. Like they're all very close and well connected to each other.
Yeah, and you might feel pain in your womb. It might be coming from your womb, but you can't really pinpoint exactly where that's coming from,
Yeah.
because the nerves that supply your organs are a little bit more vague in how they tell your brain where that pain is.
And because
you might
they're
feel it
close
somewhere
together,
else.
is this why if someone is pregnant, it can make them need a wee more?
Yeah.
Because it's pressing on the bladder.
There's different reasons for that, like the actual physical uterus compressing the bladder, but also you have hormones that can make you more likely to go to the toilet more frequently, and also an increased blood volume, so you actually wee more because you've got more blood. Yeah.
So there's lots of different things there. But if you've got kind of other things in your womb, so if you have, for example, fibroids that are making your womb really very bulky, and they're sitting on to make your womb facing more forward or more backwards, you could see that you'd get more symptoms in your bladder or more symptoms in your bowel, depending on where it sits. They're just very close in proximity, and you can see, especially with the nerves being vague, it's difficult to understand sometimes where things, and that's why when people do have gynae conditions, they can get pain kind of everywhere. It's not really very localized. They're getting pain that's kind of spread throughout their tummy, they're getting pain that's going down their legs, they're getting pain in the lower back, because when the nerves are sensitized, it kind of it can be a bit everywhere and not very specific.
So I think that's probably why, you know, if you do go to a doctor with symptoms, we'll ask you quite a lot of questions about the type of pain, where it is, like, because it can give us some more hints, but we have to work quite closely with colorectal specialists and like other people to try and understand where the pain is coming from.
Okay.
So that's all the anatomy we wanted to cover, really, isn't it?
Yeah, I think so. Well, obviously, happy to answer any other questions on it. It may be slightly different to understand on a podcast, but I do think that you can get some words across and kind of understand how things are sat.
Yeah, we weren't going to cover, obviously there's the pelvic floor and like lots of ligaments and other parts, muscles that are in the pelvis as well. That's sort of probably a whole nother topic. But yeah, they are very important and relevant, and they are there. We're not just ignoring them.
We
they
are
there.
So we were going to move on to, we thought it was kind of important for people to understand something called the HPO axis, which it feels a bit like we're going back to biology GCSE / A-level, but just for people to get a little bit of a grasp of where things might go wrong and why it's so important to kind of understand your hormones a little bit. So the HPO axis is the hypothalamic pituitary ovarian axis. Loads of massive words. So basically it means somewhere in your brain speaks to another organ that is high up in your head, and then that speaks to your ovaries. So because of that axis and because of that kind of system where they're talking to each other, all these different bits of anatomy are talking to each other, means that that is why we have a menstrual cycle, basically. And if you think about that whole, you know, when you're putting a light switch on and if it doesn't work, you're like, oh, why is it not working? And it could be because the light bulb's not working and you need a new bulb. It could be because the wires aren't working. It could be a problem with the switch. So when we're seeing people with problems with their periods, we have to think about this axis. We call it an axis, so kind of just a talk back system, like a feedback system.
Each organ releases messengers to the next one, but they also talk back to the other two.
But they either talk positively or negatively back.
So it's all, they're all communicating with each other all the time.
And I think it's important for us to understand, if you come and you have issues with your periods, we need to see where in that loop, where in that electrical system, where in your body, where is something going wrong, because then we can kind of think about how we're going to treat that, what's the problem, what could help you with that. So it's really important to understand that it's not just your ovaries that are kicking out hormones.
They're not doing everything.
No. It's like there's a whole kind of
it's
feedback.
like a beautifully orchestrated system that should work well, but sometimes goes wrong.
So could you give us a bit of a run through of the system?
Yeah. So we start at the top. So hypothalamus, area in your brain, that releases a hormone called gonadotropin releasing hormone. GnRH.
That's basically easier to
remember. That is released. So after puberty, it's released in a pulsatile manner, which basically means it sort of goes up and down. It's not constantly released at the same level, up and down. And that hormone communicates with the pituitary, which is a little area just underneath your brain,
Yeah.
I suppose, behind your eyes, that tells the pituitary to release 2 hormones. We've talked about these before. So they're follicle stimulating hormone, FSH, and that does what it's called. It tells your ovaries to produce eggs, which are formed in follicles.
We discussed the FSH quite a lot in the HRT episode when we were talking about, come on,
Yeah.
When they were
Release
attacking.
Yeah.
Yeah.
So the FSH does do that routinely.
And then luteinizing hormone, LH, is released, and it's released again from the pituitary, and that hormone is key in telling the ovary to release 1 egg around ovulation.
Yeah.
So those 2 hormones are released at different levels over the menstrual cycle. So I guess if we just, GnRH, that's probably all we need to say. Pulsatile from the hypothalamus to the pituitary tells them to produce these 2 really important hormones. Those 2 important hormones, the first part, so after your period, when you've just finished your period, before ovulation, the FSH is starting to increase. So the pituitary is telling your ovaries to start getting ready to ovulate, start producing some healthy follicles, and then around the middle, LH peaks, and that tells one egg. It tells your ovary to release 1 egg. Yeah. So it's kind of like a little fine balance, telling your ovaries what to do.
Yeah.
The negative feedback of that basically is that each of those hormones, so like when your FSH is high, it goes back to your hypothalamus and tells it to not produce any more GnRH because I've already doing what you told me.
Yeah.
So it doesn't tell the hypothalamus, the pituitary, to do anything else until it's done with that job, if that makes sense. Yeah.
So it's really very important. I don't think you need to know the ins and outs of it, but I think if you have a gist that you have this access, that's very important, and that any stage of the access could be broken, and it's really affected by stress. It's affected by exercise. It's affected by different changes that you can go through. And I think when people kind of miss a period or have 2 periods close together or that kind of thing, you really try and look into kind of, well, what's been going on in your life as well, because it's not just kind of, this doesn't carry on its job when you've got other stuff going on, because it's a bit fight or flight of let's just it does get upset. It does get upset.
Yeah, and like people who exercise a lot, like athletes, you often hear about them not having periods, and that's because if you exercise a lot, it can kind of shut down this axis, and it can mean that you don't produce as much. Yeah, it's essentially like, this isn't a good time to get pregnant. Your body's like, this is not a good time. We wouldn't survive.
We are working on other things right now.
So it's clever, and it tells the whole axis to shut down, so you don't then ovulate and you can't then get pregnant. Obviously that has implications. But it's one of the reasons. So like stress, lots of excessive exercise. Illness as well can stop this whole thing happening.
So it can be stopped at different stages if there are different conditions going on. So that's why it's important. You don't need to know it off by heart, but it's just important to know that it can be affected really quite easily. Okay.
And then the hormones that the ovaries produce, we've talked about before, but estrogen, progesterone, but also androgens, which are considered male hormones but are produced in women as well. And we'll talk about how they affect the endometrium in terms of the menstrual cycle.
So these hormones are all involved in the menstrual cycle as well?
Yes.
Yeah.
They're the hormones that, these are the signals that make you have a menstrual cycle.
Yeah. So although the ovaries do produce estrogen, progesterone and androgens, estrogen specifically can be produced in body fat. So androgens can be converted in body fat to estrogen. So if you have more body fat, then you have more estrogen, which is important because if you're someone that has like an estrogen sensitive condition like fibroids or like endometriosis, having excess body weight can actually make those symptoms a bit worse, and hence why you're often advised to lose weight if you are a little bit overweight. That's the kind of thinking behind it. It's not just being mean and saying lose weight while you're also struggling with your periods. It's like there is actually a reason
not what you need
for
at all,
that.
but it's the same with endometrial cancer. So people that have got excess body weight will have excess estrogen, and you are there more at risk of having an endometrial cancer because you've got estrogen again bombarding that lining of your womb, and we don't want that to happen. Basically,
Too much is not a good thing.
too much is not a good
Just
thing.
the right amount.
Just the right amount.
much a story about. So should we have a little walk through the menstrual cycle?
Yeah.
Okay, so menstrual cycle, I know that we've kind of discussed this previously in the episode about getting pregnant, but obviously people might not have listened to that if they're like, oh, well, I don't want to get pregnant, so don't need to listen to that. So we'll give you a little walk through what we would say is kind of a normal menstrual cycle, and then you can see in other episodes how this is affected by different conditions. So menstrual cycle means kind of you having periods on kind of a monthly basis-ish.
And it's kind of, you can split it into what's going on in the endometrium and what's going on in the ovary, but they happen at the same time.
Yeah.
Which I find quite useful to like break it up.
Yeah, so there's loads of interchangeable names. So I think when you go to kind of clinics or when you're trying to learn about these things, people will be like, well, which is the proliferative stage, and is that related to the luteal phase? Is that, and I don't think anybody needs to know that kind of stuff. You need to just know that the menstrual cycle in itself is broken into different phases. So it starts on day 1 with your period. And that's because we've kind of lost all these hormones, there's no pregnancy there, so your body's saying, right, we can shed that top layer of the endometrium. So the endometrium, the lining of the womb, the top layer of the lining of the womb, which we call the functionalis layer, is shed, completely shed. So you get a new endometrium every month, which is like totally amazing, like
it's
scarless regeneration. So you have a new endometrium made, there's no scar where you've had a cut or anything like that, and it's ready again to be like, right, are we going to get pregnant this month?
Oh, it's very optimistic.
Yeah.
Poor thing.
Every month, come on, are we ready, guys?
Try again.
So you have your period at the beginning, and that's because of the lack of hormones, basically, this shedding, this blood loss, and we know lots of people can have issues with the periods, and we're going to go on to different kind of conditions that you can have, but
I guess as well with the menstruation bit, the period bit, it's different for different people. The amount you bleed is different for different people. You have these like normal limits, really. So like most people probably bleed for around 5 to 7 days. It might start off really light. It might start off like pinky, and then it might go into full red, heavy bleeding. And then at the end, it's usually brown because that's sort of like old blood. It's not actively bleeding anymore, but you're still shedding a bit. It can vary. We don't really like to say it's heavy if you bleed more than a certain number of mils. If you feel
although
like
there is like a cut off,
it's
80 mils.
Well, who measures, you know? But if your periods are heavy for you, if it's affecting your life, if it's causing problems, then we would call that symptom heavy periods, and then we try and investigate why you're having them and how we can help treat them.
Totally. And as soon as it starts shedding, it starts repairing as well. So you have this process of shedding and repair at like the same time, which is like,
she's very
super
clever.
So super clever. So you have that because of lack of hormones, and then in the first part of your cycle, which is like the proliferative part of the cycle, the endometrium is getting thicker and thicker under the influence of estrogen.
So it's rebuilding, isn't it? Regrowing.
So it's getting, it's kind of gaining the depth, basically,
growing
in that first bit.
She's getting thick.
She's getting thick. Well, she's getting ready for you for an implantation. So getting ready for an implantation under the effect of estrogen. So the first part of your cycle, estrogen. And then midway through the cycle, you have a surge of that hormone, that LH that we discussed before, which has told your ovary to ovulate. So you will release an egg.
It gets wafted.
Through
the
tube. Egg with the LH. You've got that LH peak, and then the second part of the cycle, the secretory part of the cycle, is dominated by progesterone. You still have estrogen there, and LH just does like a big peak and then drops off. But you've got that progesterone and the estrogen in the second part of your cycle, but progesterone is dominating, and the progesterone again is making the endometrium basically just ready for implantation. So it
does
ready.
actually like release some fluid. So the secrete, it's called secretory, which is a bit weird, but it does kind of actually secrete fluid to help support this.
The glands are kind of ready. The glands are
are
kind of just ready. They're kind of
ripe.
ready for pregnancy. So progesterone is in the second part of your cycle, so the secretory part of the cycle, and then if there's no pregnancy, your body understands there's no pregnancy, and all the hormones again drop off again, and you have your next period.
And also in the ovaries at the same time, as we said before, the first part is telling your endometrium to get thicker and grow. Then ovary releases an egg. But then after the egg is released, so in your ovary you have these, we call them follicles, they're little black dots on scan. When you have ovulated, one of these follicles is bigger than the rest. It releases the egg and then it stays there, and it's called a corpus luteum. And basically that produces progesterone, and then that supports the endometrium and the egg and potentially the pregnancy if you get pregnant. But you can see it on an ultrasound scan. And sometimes they hang around and they get a little bit bigger, and then people are often told they've got a cyst. But it's actually very normal to have, like, this is part of your ovary follicle. And if it does stick around for a little while, they tend to just go away after a few months. But yeah, it's quite common if you for some reason had a scan and you just ovulated, you might be told, oh, maybe there's a cyst there, but it's often it's a normal part. It's normal to have a little cyst on your ovaries. That's how they work.
You need that corpus luteum if you're going to get pregnant, because that will be producing the progesterone. So we need that. It's massively helpful in the reproductive cycle, basically.
And we're often told that the menstrual cycle takes 28 days. What do you reckon, true or false?
Absolutely not.
Not always the same.
It's nice and easy when you're describing it. I mean, sometimes it could be in 28 days, but
some people
not
are
always.
Bob on
Some people are the textbook.
You know, it can be, I think up to 35 days is considered normal. Normal.
And if it is 28 days, then you ovulate usually around day 14, so it will be partway through your cycle. But it's kind of random, so you ovulate 2 weeks before you have a period. So if your cycle is 35 days, you will ovulate 14 days before that, not at day 14.
Okay, not 50%, 14 days before. Okay.
And
So-
even the 14 days isn't set in stone. It might be like
it's not set in
13,
stone.
15,
Yeah.
but
But
that
close.
second part is
Yeah.
a little bit
So
more fixed.
if people have longer cycles, you ovulate kind of later, and that's normal. So you don't ovulate 50%, you ovulate 14 days before your period, which is like, it's that kind of, in hindsight, you knew when you ovulated, but looking forward, you couldn't plan it if you were having a longer cycle. So
that's the whole thing we wanted to talk about, I think.
I
Is there
think so. We
anything
don't really
else?
want to go into pathologies and stuff today.
I mean, we could talk about this all day.
Oh my
We
God,
obviously love
actually,
this
all
stuff.
day. This is actually everything we need.
But yeah, I think that's the kind of information that it would be nice for people to have, like to understand what's going on in your own body.
We do
without
have some
getting too technical.
questions as well.
Go for it.
If we could ask you a few questions. Okay.
We're like,
So the first one we've got is about something called spotting. So I understand that that's the bleeding, sort of not your period, but in between times. And people are asking, what might that be? Why does it happen? Is it okay? Should they be worried?
Okay, so you shouldn't really have bleeding in between your periods. Some people have like a tiny bit of spotting after they've ovulated, and they've always had it, and that's normal for
That's
them.
just their cycle.
I would accept that. Anything else outside of that is considered abnormal, and you should see a doctor about it. I'm not saying it's going to be anything bad, but you shouldn't be having bleeding outside of your periods. And it could be related to something simple like a polyp. A polyp is like a growth in the lining of your womb, which are usually completely nothing to worry about, but we can remove those for you. So you shouldn't be having bleeding in between your periods. You shouldn't be having bleeding after sex. And see somebody if you're having either of these things, because you do need further investigations.
And it could be, sorry,
No,
just to add, it could be coming from various different
Yeah.
parts. Like, you know, if you had a little fissure, a little cut in the vulva, that might cause a bit of bleeding. You could have something on your cervix that is called an ectropion, which is just like a hormonal change that makes it a little bit more likely to bleed. That can cause bleeding after contact, so after sex, you might get a bit of bleeding. Or it could be around ovulation, or a little bit of a weird menstrual cycle. You might have a little bit of spotting there as
So
well.
there's so many reasons.
Different
There's
reasons,
there's
but
loads of
worth
things, but I
getting
don't
checked
think
out.
we should minimise them. I
Yeah.
think if you've got new onset of something that's abnormal for yourself, and it's happened over a couple of months, then I would see it and get checked out.
Yeah.
Is this different if someone is on hormonal contraception and they have like breakthrough bleeding?
Yeah, it's more common on if you say, for example, you're taking a combined pill where you're on something that's got both estrogen and progesterone compartments and components, and you take it back to back because you're you don't want to have a period, and that's totally fine. You might then have something that we call breakthrough bleeding, which is where the lining of the womb just randomly has a little blip. And that's quite common on those tablets. So it's less worrisome. If it's annoying you, maybe change the pill. But it's less worrying.
Is it ever a sign if you have breakthrough bleeding on the pill that you should take a break from the pill?
You could have a break and then have a period and then go back on it, or you could just have your period while you're on the pill and keep taking it. Different people find things work for them better or worse. I don't think there is a 100% right answer, but having a bleed every so often is not beneficial or detrimental. But if your body's decided that it's going to have a bleed, then you could have a few pill-free days and then start again.
Another question which I think we've slightly touched on is, what is the hymen, and does its absence or presence affect reproductive health?
Yeah, I feel like we've covered that. No, it doesn't. It has no function.
No function.
Interesting but useless.
What we have talked about quite a lot in this one, I would say, is the word cyst. We've talked about it for sort of like those glands, and you can get cysts, but also on the ovary. I think we should maybe say, like, are they the same idea? Are they the same thing? Because we've had that balloon analogy, but then we've said that on the ovary it's like almost a burst balloon where it's let out the follicle.
I think so. Cyst is typically like fluid-filled sac, basically. Part of the normal functioning of the ovary is to have follicles which look like tiny cysts on scan, but they're normal. When we're talking medically about like a cyst that's a problem, it's usually big. So it's usually something that's like, bigger than the normal size
over
follicles
5 centimetres, like big. Usually actually over 7 centimetres for us to do something about it there and then.
And then like cysts on the other sort of vulval cysts, they generally shouldn't be there, so there tend to be something abnormal, but may or may not need treatment, may or may not be a problem.
Cysts on the ovaries are very functional, so normal. We would say physiological, as in
they're meant to be there
and go.
They have a job.
It doesn't matter.
They have a
about
function.
them.
Unlike the hymen.
I feel we've covered most of the questions throughout this.
Fab.
Another one was just, what are fibroids and how do they impact the uterus? So Lorna's doing some research on fibroids.
She's our fibroid lady.
So fibroids, the medics will tell me if I've gotten this any wrong, but they're growths in that myometrium, so that's the muscle of the uterus that we talked about, and they aren't cancerous, so they're not an issue in that regard, but they do cause a lot of bad symptoms. Heavy bleeding, chronic pelvic pain. We talked about the order of the bladder, womb, bowel. They cause like issues with bathroom moments. So
and we're going to do a whole episode on fibroids.
I feel like that was like a 5 second.
I'm like, how did I do my whole PhD in 1 moment?
That was really good.
That was good. But I think fibroids can be anywhere in the womb. They can be pedunculated, so they can be outside of the womb practically completely. They can be in the lining of your womb, and those ones really do cause heavy bleeding quite a lot of the time. And they can be massive. They can degenerate, they can cause loads of pain.
So much that we can talk about.
So much stuff
and we will. We're
episode.
going to do a full episode on fibroids.
Because some people don't know they've even got them.
No. After 40, most people will have like fibroid change.
Yeah, definitely.
Let's not go into that.
That's all the questions. We seem to address them before we even got to the questions this time.
I think that's a sign of a comprehensive episode, guys. I feel like we've done very well.
Pat yourself on the back.
So we're going to wrap up with a bit of a disclaimer. So none of the information that we're giving, it should be taken as medical advice. These are all our own opinions, and they're not affiliated with where we work.
Make sure you're following us on wherever you're listening to this, wherever you get your podcasts.
And make sure you follow us on our social medias, which is @Between2Ovaries on Instagram, TikTok, Facebook, all the above.
All of the places. And our next episode, excitingly, will be on PCOS, so polycystic ovarian syndrome. Loads of people want us to speak about it, and we're really excited to do that episode.
So we'll see you there.